Right now, up to a third of the people listening to this have a rogue microscopic piece of tissue just kind of floating around somewhere in their abdomen.
Yes. Up to a third. It's wild.
Right. Like it might be attached to your pancreas.
Yeah.
It could be clinging to your intestines.
Mhm.
And in some really bizarre cases, it might even be fused to your reproductive organs.
No, it's just, yeah, it's a terrifying thought.
And the wildest part is that it actually masquerades on medical scans as a highly dangerous tumor. So it causes absolute panic for doctors, when in reality it's just a scattered microscopic clone of an organ you barely even think about.
It really is, the ultimate medical imposter. And I mean, that's just one of the many reasons why the organ we're looking at today is arguably the most misunderstood structure in the human body.
Oh, absolutely.
Because, we all know we have one. We vaguely know it sits somewhere under our ribs. But because we can technically survive if a surgeon removes it, we've kind of culturally written it off as completely optional.
Right. It gets treated like, I don't know, the appendix is slightly larger cousin, just this vestigial blob taking up space.
Exactly.
But our mission in this deep dive is to completely dismantle that idea. Because when you actually dig into the sources, the anatomy, and the cutting-edge immunology we have on the table today, you quickly realize the spleen is anything but an optional accessory.
Far from it. I mean,
Yeah.
if anything, it's a highly advanced dual-threat fortress.
Fortress, I like that.
Yeah, it operates simultaneously as a command center for your adaptive immune system and as a microscopic recycling plant for your cardiovascular system.
Wow.
And the way it achieves this, like the actual internal plumbing, is so counterintuitive that it honestly breaks the fundamental rules of how human blood is supposed to flow.
Okay, I really want to get to that broken plumbing, because the idea that our blood just goes off-road is fascinating. But before we shrink down and look at the microscopic obstacle courses, let's just get our bearings.
Mhm.
Where exactly is this thing, and what does it look like? Like,
Yeah.
if I'm trying to locate my own spleen right now, where am I pointing?
Okay, so you want to aim for the upper left quadrant of your abdomen. Take your left hand, reach across to the left side of your rib cage, right where your ribs start to, curve around your flank.
Okay, yeah.
The spleen is tucked really tightly behind ribs 9, 10, and 11, right up against the diaphragm.
So it's protected by the rib cage, which seems like a pretty good design for something so important. How big is it exactly?
Well, in a healthy adult, it's roughly the size and weight of a smartphone.
Oh, wow, that's small.
Yeah, about 12 centimeters long, maybe 7 centimeters wide, and 4 centimeters thick. It weighs between 150 and 200 grams, and it has this very smooth, convex outer surface that perfectly hugs the dome of your diaphragm.
Okay.
But the underside, what we call the visceral surface, is a completely different story. It is pressed up against a very crowded neighborhood of organs.
Like what? What's it touching?
It touches the back of your stomach, the top of your left kidney, the bend of your large intestine called the left colic flexure, and the tail end of your pancreas.
Man, that sounds incredibly cramped. Is it just kind of wedged in there by gravity, or is it actually anchored to all those other organs?
Oh, no, it is firmly anchored. And this is actually crucial for its blood supply. The spleen is suspended by these thick folds of tissue called ligaments. Now, when most people hear ligament, they think of like a knee or an elbow,
Wow.
tough, fibrous bands connecting bone to bone.
Yeah, exactly, like the ACL or something.
Right. But abdominal ligaments are different. They're actually double folds of the peritoneum, which is the membrane that lines your entire abdominal cavity.
Oh, okay.
Think of the peritoneum like a giant, clear plastic sheet that wraps around all your organs. Where that sheet folds back on itself to connect two organs together, we call it a ligament.
Got it.
So the spleen is suspended by two main ones. The gastrosplenic ligament connecting it to the stomach, and the splenorenal ligament connecting it to the kidney.
So it's basically hanging in a hammock made of this peritoneal membrane.
A hammock that also acts as a conduit. Because these folds of tissue are hollow inside, they actually serve as the protective highways for the spleen's blood vessels.
Oh, that makes sense.
Yeah, the splenic artery and the splenic vein run directly through the splenorenal ligament.
Okay, so it's this tightly packed, highly connected organ tucked under the left ribs. But how does it get there in the first place? Because when I was reading through the embryology notes from our sources, this organ has a completely different job description before we're even born.
The origin story of the spleen is truly unique. It starts forming incredibly early, around the 5th week of embryonic development, and it originates from a cluster of what we call mesenchymal cells located in the dorsal mesogastrium.
Whoa, okay, stop right there. Mesenchymal cells. dorsal mesogastrium, you completely lost me. Paint a picture for me. Like, what does that actually look like in a 5-week-old embryo?
Fair enough. Okay, so at 5 weeks, an embryo is basically just a tiny developing tube. The gut is starting to form as this simple cylinder. Okay. The dorsal mesogastrium is essentially a primitive sheet of jelly-like tissue attached to the back of this developing stomach tube.
Right.
And mesenchymal cells are just these highly versatile, unspecialized stem cells that have the ability to morph into connective tissue, blood vessels, or lymphatic organs.
Got it. So it's a cluster of very flexible stem cells just hanging out behind the protostomach.
Exactly. And what's remarkable is what these cells do once they form the early spleen. From about the 9th week all the way to the 28th week of fetal life, this primitive spleen is actually one of the main factories in your body for creating red blood cells.
Wait, I thought the bone marrow made all of our blood.
In an adult, yes. But in a fetus, the bones haven't fully calcified yet, you know? The marrow spaces haven't developed, so the body has to rely on other organs to manufacture blood.
Oh, I had no idea.
Yeah, this process is called extramedullary hematopoiesis, literally making blood outside the marrow. The spleen, along with the fetal liver, takes on this massive responsibility. And then, as the fetus nears full term, the bones mature, the marrow takes over, and the spleen entirely shuts down its blood-making factory to focus on its adult job, which is filtration and immunity.
That is a brilliant handoff.
Mm-hmm.
But the physical construction of this organ, when those stem cells are clumping together behind the stomach, it doesn't always go according to the blueprint, right?
No, it definitely does not.
Because that brings us back to the rogue tissue I mentioned at the top of the deep dive. The statistic in the sources is staggering. Up to 30% of the population has an extra spleen.
Or even multiple extra spleens. Yeah, we call them accessory spleens, or splenonculi. And it happens precisely because of how that embryological tissue forms.
How does the body just accidentally build a second organ, though?
Think of it like this. When those mesenchymal cells are gathering to form the spleen, they don't start as one solid block. They start as a bunch of separate, tiny little droplets of tissue. As the embryo grows, these droplets are supposed to be pushed together and fuse into one single, smooth organ. Imagine taking droplets of liquid mercury on a table and pushing them together until they snap into one big pool.
Okay, I can visualize that. So what goes wrong? Does a droplet just get left behind?
Exactly. In about 1 to 3 out of every 10 people, the fusion is incomplete. One of those tiny mercury droplets of splenic tissue fails to merge with the main mass.
Wow.
It gets separated, sets up camp in the surrounding tissue, and develops its own tiny blood supply. Most of these splenunculi are small, maybe 1 to 3 centimeters across.
Where do they usually end up?
They usually hide right near the main spleen, nestled in that gastrosplenic ligament we talked about, or deeply embedded in the tail of the pancreas.
So if I have one of these little accessory spleens, does that mean my immune system is like 10% stronger? Do I have a biological advantage here?
Functionally, no. You don't have super immunity. Most people go their entire lives completely oblivious to the fact that they even have one. It just quietly filters a tiny fraction of your blood.
But if it's harmless, why did you call it a diagnostic nightmare earlier?
Because of how it appears on modern imaging. Let's say a patient comes in with vague abdominal pain. The doctor orders a high-resolution CT scan or an MRI.
Right.
The radiologist looks at the scan and suddenly sees a dense, highly vascular 2-centimeter mass sitting directly inside the pancreas, or perched right on top of the adrenal gland.
Oh, no. That is terrifying.
It is terrifying because a mass in the pancreas usually means a pancreatic neuroendocrine tumor. A mass on the adrenal gland looks exactly like an adrenal carcinoma.
Which are bad.
Incredibly aggressive, lethal cancers. So this completely benign, harmless little droplet of extra spleen tissue triggers an absolute oncological panic. The patient is told they might have cancer.
So how do you avoid unnecessarily cutting someone open to remove part of their pancreas? I mean, how do doctors prove that this terrifying shadow is just a helpful little piece of spleen?
Well, you can't just take a biopsy because sticking a needle into a suspected cancer can sometimes seed tumor cells along the needle tract.
Oh, right. You don't want to spread it.
Exactly. Instead, doctors use a brilliant functional test called damaged red blood cell scintigraphy.
Damaged red blood cell scintigraphy. Break that down for me.
It's an elegant way of exploiting the spleen's very specific biological appetite. The primary job of splenic tissue is to hunt down and consume old or damaged red blood cells.
Okay.
So doctors take a small sample of the patient's own blood. They gently heat the red blood cells to mildly damage their membranes, making them look old.
Uh-huh.
Then they tag these damaged cells with a safe radioactive tracer isotope and inject them back into the patient's bloodstream.
Oh, I see where this is going. You're creating the perfect bait.
Exactly. You put the bait in the water and you wait to see who bites. The main spleen will obviously suck up most of these radioactive damaged cells.
Right.
But if that mysterious tumor in the pancreas is actually an accessory spleen, it won't be able to resist. It will also eagerly consume those damaged cells.
Wow.
The doctor takes another scan, and if that specific spot in the pancreas lights up with radioactivity...
You know, it's just a hungry little splenunculus doing its job. That is incredibly clever. You use the organ's own biological programming to unmask it.
Precisely. It completely rules out cancer without a single surgical incision.
But dropping a piece of tissue into the pancreas isn't even the weirdest developmental glitch, right? The sources mention something called splenogonadal fusion, which sounds like two things that absolutely should not be anywhere near each other.
It is one of the strangest anomalies in human embryology. Splenogonadal fusion is exactly what it sounds like. Splenic tissue fused to the gonads, the testicles in males, or the ovaries in females.
How does tissue from under your ribs end up all the way down in the pelvis?
It has to do with how our reproductive organs develop. In the very early stages of an embryo, the primitive gonads develop high up in the abdomen, very close to where the spleen is forming.
Okay.
Normally, they separate cleanly and the gonads descend down into the pelvis or the scrotum, but very rarely a physical connection forms between them. As the gonad descends, it literally drags a piece of the spleen down with it.
That is wild. Does it drag the whole organ?
Usually just a piece, and there are two types. In the continuous type, there is a literal solid cord of functioning spleen tissue stretching from the main spleen under the ribs all the way down to the testicle or ovary.
A whole cord. Wow.
Yeah, and in the discontinuous type, the connection breaks and you just have a standalone chunk of spleen firmly attached to the gonad.
The human body is just impossibly messy sometimes. And speaking of messy, there's another anomaly here. The wandering spleen. What makes a spleen wander?
Remember those peritoneal ligaments we discussed? The hammock holding it in place?
Right, the gastrosplenic and splenorenal ligaments?
Exactly. Sometimes, due to a congenital defect, those ligaments fail to develop properly. They're either missing entirely or incredibly lax. So the spleen isn't anchored to the stomach or the kidney.
Oh, wow.
It is only attached by its vascular pedicle, the long stalk containing the splenic artery and vein.
So it's just dangling like a pendulum by its blood vessels.
Yes, and because it's heavy, it can actually drift down into the lower abdomen or pelvis. The patient might literally feel a strange, movable mass in their belly.
That sounds dangerous. If it's just swinging around by its blood supply, couldn't the cord get tangled?
That is the exact clinical emergency doctors fear. It's called splenic torsion. The spleen can flip or twist on its axis.
Wow.
And if that stalk twists multiple times, it completely chokes off the splenic artery. The organ is suddenly deprived of oxygen, leading to rapid, agonizing pain and eventual tissue death. It requires immediate emergency surgery to untwist it and anchor it down, a procedure called a splenopexy.
Okay, so we've established that the spleen can be found anywhere from its proper home under the ribs to embedded in the pancreas, or even attached to a testicle.
Sure.
But if this rogue tissue is so critical to track down, what exactly is it doing on a microscopic level? Because earlier you mentioned that the spleen is actually two different organs mashed together and that it breaks the rules of human circulation. Let's zoom in. What does the internal architecture actually look like?
To understand how the spleen functions, you have to picture its cross-section. If you slice it open, it is not a uniform block of meat.
Okay.
It looks like a dense, dark red sponge speckled with tiny grayish-white dots. We call these two zones the red pulp and the white pulp, and they have completely distinct jobs.
Let's start with those white dots. What is the white pulp?
The white pulp is your body's immune intelligence hub. It's entirely composed of lymphoid tissue. When the main splenic artery enters the spleen, it rapidly branches out into smaller and smaller vessels, eventually forming these tiny central arterioles.
Right.
The white pulp is essentially a thick, protective sleeve of immune cells that wraps tightly around these arterioles.
Like insulation wrapping around a copper wire.
A perfect analogy. We call these sleeves periarterial lymphoid sheaths. And this insulation is packed densely with T cells. These are the assassins and the generals of your adaptive immune system.
Okay, the big guns.
Exactly. And directly adjacent to these T cell sheaths are little spherical structures called lymphoid follicles, which are absolutely crammed with B cells.
Okay, so you have the T cells wrapping the blood vessel and the B cells hanging out right next door. How do they actually filter the blood?
Well, it's not just a passive filter, it's an active surveillance system. As blood flows through that central arteriole, specialized antigen-presenting cells are constantly sampling the blood, looking for foreign invaders, viruses, bacteria, fungal spores.
Like little scouts.
Right. If they find a piece of a bacteria, they pull it out of the bloodstream and present it directly to the T cells in the sheath.
They're essentially holding up a mugshot to the immune generals.
Precisely. If the T cells recognize the mugshot as a threat, they sound the alarm. They immediately activate the B cells in the neighboring follicles.
And what do the B cells do?
Those B cells kick into high gear, transforming into plasma cells that pump out massive amounts of highly specific, customized antibodies.
This brings us to a really crucial term in the sources: opsonization. The spleen is famous for making opsonizing antibodies. I need you to explain how that works, because it seems to be the main reason people without a spleen are in such danger.
To understand opsonization, you have to understand the enemy. Certain very dangerous bacteria like Streptococcus pneumonia or Haemophilus influenza have evolved a brilliant defense mechanism.
Okay.
They surround themselves with a thick, slimy capsule made of complex sugars.
Like a microscopic force field.
Or a layer of grease. Your immune system has frontline soldiers called macrophages, whose job is to physically grab bacteria and eat them. But when a macrophage tries to grab a capsulated bacterium, it literally slips right out of its grasp. The macrophage can't get a grip on the slimy surface.
So the bacteria is just acting like a greased pig at a county fair.
Brah.
Your immune cells are chasing it, but they can't actually tackle it.
Exactly. This is where the spleen's white pulp saves your life. Those B cells analyze the chemical makeup of that specific slime capsule and manufacture opsonizing antibodies.
Okay.
Think of these antibodies as microscopic, double-sided strips of Velcro. One side is custom designed to stick permanently to the bacterial slime. The other side is designed to stick perfectly to a macrophage.
Oh, that is brilliant.
The B cells flood the bloodstream with millions of these Velcro tags. They stick to the bacteria, completely coating it. This process is called opsonization.
Wow.
Now, when the macrophage encounters the bacteria, it doesn't slip away. The macrophage grabs the Velcro handle, pulls the bacteria in, and destroys it. The spleen is the primary manufacturing center for these specific Velcro tags.
So that's the white pulp, the intelligence center painting targets on the slippery invaders. But you said the spleen looks mostly like a dark red sponge. That brings us to the red pulp, which makes up the vast majority of the organ. What is going on in there?
The red pulp is entirely focused on blood filtration and recycling. It consists of two main architectural structures: the venous sinusoids, which are basically wide, leaky blood vessels, and the splenic cords, also known as the cords of Billroth.
The cords of Billroth. That sounds incredibly dramatic.
It is the site of the most brutal cellular testing in the human body. And this is where we have to talk about the broken plumbing.
Right, the off-road blood.
Yes. In virtually every other organ in your body, your brain, your muscles, your kidneys, blood flow is what we call closed.
Meaning the blood stays inside the pipes. It goes from arteries down into microscopic capillaries and then back up into the veins. It's a closed loop, like the plumbing in my house. Water doesn't just leak out into the walls.
Precisely. The blood is always contained within an endothelial cell wall, but the spleen has evolved both closed and open circulation. About 10% to 30% of the blood flowing into the spleen takes the normal closed capillary route, but a staggering 70% to 90% of the blood takes the open path.
I am having a hard time picturing this. What does open path mean? Does the blood vessel just end?
It literally just ends. The tiny terminal arterioles in the red pulp don't connect to capillaries. They simply open up and dump the raw blood directly into the interstitial tissue space, specifically into those cords of Billroth.
Wait. So 90% of the blood entering the spleen is just bleeding freely into the organ. How is that possible? How does the spleen maintain any blood pressure? How does it not just balloon up and explode from the pressure?
It's a fantastic question, and it is the central paradox of the spleen. The moment the blood leaves the arteriole and enters the cords, the blood pressure plummets drastically.
Okay.
And it doesn't pool like a cavern filled with liquid. The cords of Billroth are a dense three-dimensional meshwork. Think of a thick, tangled sponge made of reticular fibers, collagen, and thousands of resident macrophages. The blood percolates very, very slowly through this dense thicket.
So it's not a burst pipe filling a room, it's water slowly seeping through a dense swamp.
Exactly. And that slow percolation is entirely by design. Because the blood is moving at a crawl through this open mesh, every single red blood cell is forced into intimate, prolonged contact with those resident macrophages.
Like a pat-down.
It is the ultimate security pat-down. The macrophages are inspecting the cells, looking for antibodies, looking for parasites, but the hardest part for the red blood cell is yet to come. Once it survives the swamp, it has to find its way back into the closed circulatory system to get back to the heart.
Right, it can't just stay in the swamp forever. How does it get back into the pipes?
It has to pass a brutal physical fitness test. To re-enter the venous sinusoids, the red blood cell has to physically force its way through the walls of the vessel. The walls of these sinusoids are constructed from highly specialized, elongated cells called stave cells.
Like the wooden staves of a wine barrel.
Exactly like a barrel. The stave cells run parallel to each other, forming a cylinder. And between these cells are incredibly narrow, microscopic slits. The gaps are actually smaller than the diameter of a red blood cell.
Okay, so I'm picturing a military obstacle course.
Yeah.
The red blood cell has crawled through the mud of the swamp, and now it faces this massive fence with tiny, narrow gaps it has to squeeze through to survive.
That is exactly what happens. We call this the culling process. A young, healthy red blood cell is incredibly flexible. It's essentially a pliable bag of fluid.
Right.
It can deform itself, squish down into a tiny oval, slide through that microscopic slit between the stave cells, and pop out safely on the other side into the venous circulation.
But red blood cells don't live forever, right? What happens when they get old?
A red blood cell has a lifespan of about 120 days. Over those 4 months, it gets battered as it circulates through the body. Its cell membrane oxidizes, proteins degrade, and it gradually loses its elasticity. It becomes stiff and rigid.
It loses its flexibility to get through the fence.
It does. An old, stiff red blood cell reaches the stave cells, tries to squish through the tiny slit, and it gets stuck halfway. It physically cannot compress enough to pass. And what happens when a cell gets trapped in the open cords?
The bouncers catch it.
The bouncers catch it. A macrophage is always waiting right there at the slits. It sees the trapped, struggling cell, engulfs it entirely, and destroys it. That is how the spleen culls the old and damaged cells from your blood, keeping your circulation fresh.
It's incredibly ruthless, but perfectly efficient. It's purely mechanical sorting. If you bend, you live. If you're stiff, you get eaten.
Yep.
But it's not just a binary choice of life and death, is it? The sources mention a process called pitting, which sounds even more surgical.
Pitting is a marvel of cellular biology. Sometimes a red blood cell is generally young and flexible, but it has a specific, localized defect inside it.
Like what?
For example, maybe there's a little chunk of oxidized, clumped-up protein called a Heinz body. Or maybe when the cell was formed, it failed to eject a tiny remnant of its nucleus. We call it a Howell-Jolly body.
So it's a good cell with a piece of internal trash.
Yes. When this cell tries to squeeze through the stave cell slit, the flexible part of the cell slides through just fine. But that rigid little chunk of protein or DNA inside gets caught on the narrow opening.
It's like trying to pull a deflated balloon through a keyhole, but there's a marble stuck inside the balloon.
A perfect image. The cell is stuck, but it's mostly healthy. So instead of destroying the whole cell, the macrophage approaches the trapped portion and literally bites off the section containing the defect. It plucks the rigid inclusion out. It pits the cell, much like a machine taking the hard pit out of an olive or a cherry. The cell membrane quickly seals itself back up, and the slightly smaller but now completely clean red blood cell continues on its way back to the heart.
That is microscopic surgery happening millions of times a second inside us. But let's look at the aftermath of the culling. When those macrophages destroy millions of old, stiff red blood cells every day, they don't just dump the waste into the bloodstream, do they?
Absolutely not. The body cannot afford to be wasteful, especially with iron. The primary component inside a red blood cell is hemoglobin, the protein that binds to oxygen.
Right.
And at the core of every hemoglobin molecule is an iron atom. If the spleen just threw that iron away every time it destroyed a cell, we would bleed out our iron stores and become lethally anemic in a matter of weeks.
So the spleen acts as a recycling center.
A highly efficient one. When the macrophage engulfs the old red blood cell, it uses enzymes to dismantle the hemoglobin. It carefully extracts the iron atoms. The macrophage can either store that iron safely inside its own cytoplasm for later use, or it can load the iron onto a transport protein called ferritin. The ferritin carries the salvage iron back into the bloodstream, shuttling it directly to the bone marrow to be used as the raw material to build brand new red blood cells.
It is an endless, perfect loop. But here is where we hit a truly fascinating piece of modern research. You added a recent study to our deep dive pile, published in Nature Aging by the Technion Faculty of Biology.
Yes.
And it suggests that this very iron recycling system might be the hidden reason why our immune systems crash as we get older.
It is a groundbreaking study because it connects the two different halves of the spleen, the red blood cell recycling the red pulp and the immune function of the white pulp.
Okay, how so?
We've known for decades that as humans age, our immune response weakens. Specifically, our T cells lose their ability to mount a strong attack against new viruses. We always just assumed the T cells themselves were getting old and tired.
But the study says it's not the T cell's fault, it's the environment.
Exactly. The researchers looked at the red pulp. The spleen is processing millions of iron-rich red blood cells every day for decades. Iron is a highly reactive oxidative element. Think about what iron does when it's exposed to oxygen and water over a long time.
It rusts.
It rusts. Over decades, the macrophages in the spleen become slightly less efficient at processing and exporting the iron. Iron deposits begin to accumulate in the tissue. Toxic, oxidized byproducts build up.
Oh, wow.
The spleen slowly transforms into a highly oxidative, iron-toxic environment. It literally begins to rust from the inside out.
So the recycling center is polluting the surrounding neighborhood, and the T cells in the white pulp are right next door.
Precisely. The researchers discovered that when these vital T cells are forced to live in this rusty, iron-toxic environment, they go into survival mode. Iron toxicity can kill a cell. So to protect themselves, the T cells drastically downregulate their own iron uptake. They shut their doors and refuse to take in any more iron.
Which sounds like a smart defense mechanism.
It is, until an infection hits. Because here is the catch. A T cell requires an influx of iron to rapidly divide and mount an immune attack. Iron is the fuel for clonal expansion.
Oh, I see.
But because the T cell has locked its doors to survive the toxic environment of the aged spleen, it cannot take up the fuel it needs. The alarm rings, but the soldiers have no ammunition. They fail to respond.
That is tragic. The very process the organ uses to keep our blood clean eventually creates the rust that suffocates our immune defense. Can we fix it?
That's the most exciting part of the study. The researchers found that if they carefully bypassed the toxic environment and supplemented iron directly to the T cells precisely at the moment of activation, the T cells immediately woke up.
Really?
Yeah, they were able to reverse the immune decline in elderly models, essentially restoring youthful immune function.
That completely reframes how we look at aging and immunity. It's an incredible system, but clearly it is delicate. The meshwork, the culling, the recycling, it only works when everything is balanced. But what happens when that balance is shattered? I want to move into how the spleen reacts when the body is under siege. Because the spleen doesn't just passively accept a problem, it fights back. And sometimes it fights so hard it becomes the problem itself.
You're talking about splenic overdrive, splenomegaly.
Exactly. Literally, an enlarged spleen. Our sources make it clear that the spleen is a highly reactive organ. If you put more stress on it, it physically grows. But what exactly causes it to swell up?
Well, the causes of splenomegaly depend entirely on the patient's geography and underlying health. We categorize it generally into infectious, congestive, infiltrative, and immune causes.
Okay, let's break those down.
Let's start globally. If you look at tropical regions, the massive driver of enlarged spleens is parasitic infection, specifically malaria, leishmaniasis, and schistosomiasis.
Let's use malaria as the example because that directly involves the red blood cells. How does a mosquito bite cause your spleen to inflate?
It comes down to the brutal efficiency of the malaria parasite Plasmodium. When an infected mosquito bites you, it injects the parasite into your bloodstream. The parasite eventually invades your healthy red blood cells.
Right.
It hides inside the cell, feeds on the hemoglobin, and rapidly multiplies until the red blood cell literally bursts, releasing thousands of new parasites to infect more cells.
Okay, so your bloodstream becomes a war zone filled with cellular debris and parasites.
And remember the red pulp, that open circulation system? All of that raw, infected blood is being dumped into the dense meshwork of the splenic cords. The resident macrophages suddenly detect millions of infected, rigid, and destroyed red blood cells. The spleen recognizes a massive systemic threat.
So it calls for reinforcements.
Exactly. It undergoes what we call work hypertrophy. To handle the massive influx of cellular garbage and infected cells, the spleen vastly increases its production of immune cells. The lymphoid follicles swell, the macrophages multiply to eat the infected cells.
And it just physically gets bigger.
Right. The organ physically inflates to accommodate the required workload. In areas where malaria is endemic, it is common to find people walking around with spleens 2 or 3 times the normal size simply because the organ is constantly fighting a low-grade war.
It makes perfect sense. It's immune response. But what about in places without malaria? The sources highlight that in temperate climates, one of the leading causes of splenomegaly has nothing to do with infection. It has to do with the liver.
Yes, hepatic cirrhosis leading to portal hypertension. This is where we have to revisit the fluid dynamics of the abdomen. We talked about how blood enters the spleen, but we need to track where it goes when it leaves.
Right. It leaves through the splenic vein. Where does that vein go?
The splenic vein travels away from the spleen and eventually merges with veins coming from your intestines. Together, they form a massive, critical blood vessel called the hepatic portal vein. And this portal vein empties directly into the liver.
So the blood from the spleen has to flow through the liver before it goes back to the heart. The liver is downstream.
That is the key concept. The liver is downstream. Now imagine a patient who has developed severe cirrhosis of the liver, perhaps from decades of chronic alcohol use or an untreated hepatitis C infection.
Okay.
Cirrhosis means the normally soft, spongy tissue of the liver is replaced by hard, fibrotic scar tissue.
So the filter's clogged.
Completely clogged. The blood flowing up the portal vein hits this wall of scar tissue and cannot pass through efficiently. The pressure inside the portal vein skyrockets. We call this portal hypertension.
It's like a massive traffic jam on the highway.
Or a clogged kitchen sink. If the drain pipe is blocked, the water backs up. In the body, this high-pressure blood backs up all the way down the portal vein and directly into the splenic vein. The pressure literally forces blood backward into the spleen.
Oh, wow. So the spleen is just inflating like a balloon hooked up to a hose.
We call it congestive splenomegaly. The spleen becomes heavily engorged with trapped venous blood it can't drain. Over months and years, this chronic high pressure and stretching cause the spleen tissue to remodel itself.
Remodel it?
It undergoes hyperplasia, creating more tissue to handle the stretch, and it develops dense fibrosis. It becomes a hard, enlarged, congested organ.
So a normal spleen is, what, 150 grams? How big can a sick spleen actually get?
It can reach truly staggering proportions. Remember, a healthy spleen is hidden so far up under the rib cage that a doctor cannot feel it from the outside. If a physician presses on your abdomen and can feel the edge of your spleen, it is already 2 to 3 times its normal size.
Wow.
But the sources also detail a clinical category called massive splenomegaly.
Massive, in medical terms, usually means something terrifying.
It does. Massive splenomegaly is defined as a spleen that extends more than 8 centimeters below the edge of the rib cage. It can cross the midline of the abdomen. It can literally reach all the way down into the pelvis. These spleens can weigh several kilograms.
Multiple kilogram organ taking up the entire left side of your abdomen. What causes it to get that massive?
Cirrhosis.
Even cirrhosis rarely causes it to get that big. When we see a massive spleen crossing the abdomen, we're usually looking at severe infiltrative diseases, like cancers.
Exactly. Primary among these are blood cancers, myeloproliferative disorders like chronic myeloid leukemia or CML, or a rare cancer called hairy cell leukemia. The bone marrow goes haywire and produces billions of malignant, defective white blood cells. These cancer cells migrate to the spleen and physically pack the organ full, expanding it to enormous sizes.
The cancer just uses the spleen as a storage locker.
Exactly. Another cause of massive splenomegaly is metabolic storage disorders, like Gaucher disease. This is a fascinating genetic condition. The macrophages in the spleen are supposed to break down cellular waste, right?
Right.
But in Gaucher disease, the patient is missing a specific enzyme needed to break down a type of fat called a glucocerebroside.
So the bouncers eat the trash, but they can't digest it.
Precisely. The fat accumulates inside the macrophages. They gorge themselves but cannot process the fat, so they just swell up massively. Millions of these swollen, fat-filled macrophages accumulate, and the entire spleen balloons outward.
Having a multi-kilogram organ crushing your other organs has to cause its own set of symptoms, right?
It certainly does. A hallmark physical symptom of a massively enlarged spleen is early satiety. Remember the anatomy from earlier. The spleen's visceral surface is pressed directly against the stomach. As the spleen grows to 10 times its normal size, it physically compresses the stomach into a tiny tube.
So you sit down for a meal, you take 3 bites of a sandwich, and you feel completely stuffed because your stomach physically cannot expand to hold the food.
Exactly. Patients rapidly lose weight, but the physical crowding isn't even the most dangerous part of an enlarged spleen. The true danger is when the organ becomes too good at its job, when it shifts from being a helpful filter to a hyperactive rogue operative.
Hypersplenism.
Hypersplenism. This is a critical concept for anyone studying the blood. When the spleen hypertrophies, when it gets abnormally large, it loses its fine-tuned selectivity.
What happens?
The stave cell slits stretch, the macrophages become hyperreactive. It no longer just calls the old and damaged cells, it starts trapping and aggressively destroying perfectly healthy, vital blood cells.
It's the bouncer throwing everyone out of the club, even the people who just arrived and are behaving perfectly fine.
Yes, and it creates a cascading blood crisis for the patient. Because the spleen is chewing up healthy red blood cells, the patient develops severe anemia, leading to crushing fatigue and shortness of breath. Because it's destroying healthy white blood cells, leukopenia, the patient loses their ability to fight off simple infections. And crucially, it traps and destroys platelets.
Platelets are the cells that clot the blood, right?
Correct. When platelet counts drop dangerously low thrombocytopenia, the patient is at severe risk of spontaneous bleeding. They might develop tiny pinpoint red bruises all over their skin called petechiae, which are basically microhemorrhages in the capillaries.
Yeah, it's scary.
Their gums bleed when they brush their teeth. If they sustain a minor injury, they could bleed to death internally.
And what happens to all the waste? If the spleen is destroying blood cells at 10 times the normal rate, the recycling center must get backed up.
It does. When red blood cells are destroyed, the hemoglobin is broken down into a yellow pigment called bilirubin. The spleen ships this bilirubin to the liver to be processed and excreted in bile.
Okay.
But in hypersplenism, the spleen is dumping such a massive volume of bilirubin into the system that the liver cannot process it fast enough. The excess bilirubin backs up into the blood, depositing in the skin and the whites of the eyes. Jaundice. And because the bile becomes supersaturated with this bilirubin, the patient is at extremely high risk of forming painful pigment gallstones.
The downstream effects are just devastating. But the spleen doesn't always go rogue just because it gets physically swollen, right? The sources outline a condition where the spleen is normal size, but the immune system essentially tricks it into executing innocent cells.
You are referring to ITP-immune thrombocytopenic purpura. This is a fascinating and dangerous autoimmune disorder. In ITP, the root of the problem isn't actually the spleen. The root of the problem is a glitch in the adaptive immune system. The B cells begin producing autoantibodies.
Antibodies that attack the self.
Yes. Specifically, they produce IgG antibodies that are programmed to target glycoproteins on the surface of the patient's own healthy platelets. The most common target is a receptor complex called GPI-IBILIA.
Think of that receptor like a barcode on the outside of the platelet. The immune system is printing out millions of target tags specifically designed to stick to that barcode.
Exactly. It is opsonizing the patient's own platelets, painting them with the exact same targets it uses for deadly bacteria. Now, the platelets themselves are perfectly healthy, they're circulating normally, but as the blood flows through the open circulation of the spleen, the macrophages in the red pulp inspect the passing cells.
And the bouncers see the target tag.
The macrophages are just blindly following orders. They are programmed to recognize the tail end of that IgG antibody. They see the tag, they grab the platelet, and they engulf it. The spleen acts as the executioner, indiscriminately slaughtering the body's own clotting factors based on bad intelligence from the B cells.
That is terrifying. If the platelet count crashes, the patient is going to bleed. How do doctors treat that? Do you attack the B cells making the tags, or do you stop the macrophages doing the eating?
Both, progressively. The first line of defense is medical. Doctors will prescribe high doses of corticosteroids like prednisone. This suppresses the overall immune system, dialing back the B cells so they stop making so many antibodies and making the macrophages a little less aggressive.
But nobody wants to be on high-dose steroids forever. The side effects are brutal.
Exactly. In an acute crisis, if the platelets are dangerously low, doctors might use IV intravenous immunoglobulin. Essentially, they pump the patient full of random donor antibodies.
What does that do?
The idea is to flood the spleen with so many generic antibodies that the macrophages become distracted and overwhelmed, leaving the tagged platelets alone for a few days so the blood can clot.
It's like throwing a massive bag of decoy targets into the club so the bouncers get confused.
A perfect analogy. But ITP in adults is often a chronic, relapsing disease. If the patient is refractory, meaning they fail to respond to steroids, IVUge, and other targeted drugs, doctors have to resort to the ultimate cure.
You fire the executioner?
You perform a splenectomy, you surgically remove the organ. The B cells might still be producing the bad antibodies and tagging the platelets, but if you remove the primary organ responsible for destroying them, the platelet count often rebounds to safe levels.
That is a drastic step, but it makes sense mechanically. Now, before we move away from how the spleen reacts to stress, I have to stop and unpack something truly mind-bending from the sources.
Oh, the brain-spleen axis.
Yes. We've talked about physical stress parasites, clogged livers, rogue antibodies, but there is a brief mention of the brain-spleen axis. Are you seriously telling me that my psychological state can physically alter my spleen?
It sounds like pure science fiction, but this is one of the most rapidly expanding fields in neuroimmunology. For a long time, doctors treated the nervous system and the immune system as completely separate entities. But modern research shows they are intimately, physically hardwired together.
Hardwired, like there are nerves directly connecting my brain to my spleen.
Yes, specifically branches of the vagus nerve. The vagus nerve is the superhighway of the parasympathetic nervous system, wandering from the brainstem all the way down into the abdomen, and it plugs directly into the spleen. It facilitates bidirectional communication. Afferent fibers send signals from the spleen up to the brain, reporting on inflammation. And efferent fibers send signals from the brain down to the spleen, commanding the immune cells.
So what happens when the brain is stressed?
Studies, primarily conducted on rodents, have shown extraordinary results. When subjects are exposed to chronic, unrelenting psychological stress, the brain sends a constant barrage of stress signals down the vagus nerve directly into the spleen. This chronic neural stimulation actually triggers an inflammatory cascade within the organ.
It physically alters the tissue.
Yes. Chronic stress literally produces splenomegaly. The spleen physically inflates and alters its immune architecture purely in response to psychological trauma.
That's wild.
The macrophages become hyperreactive, pumping out pro-inflammatory cytokines into the blood, driving systemic inflammation throughout the whole body.
Wait, let's make this practical. Are you telling me that a terrible boss, a brutal divorce, or just a really stressful month at work could physically inflate my spleen and flood my body with inflammation?
In a state of chronic, prolonged physiological stress, it is entirely plausible that systemic stress is altering your splenic architecture. The evidence is so compelling that researchers have found that administering certain targeted antidepressants, like arketamine, can actually block the stress-induced spleen enlargement.
An antidepressant shrinks the spleen.
By breaking the neural stress signal, yes. Even more radically, studies have shown that if you perform a splenectomy on a stressed animal, or if you surgically sever the specific nerve running to the spleen, a splenic denervation, the animal does not develop stress-related behavioral depression.
Hold on. You cut the nerve to the spleen, and the brain stops being depressed.
Because the communication is bidirectional. The brain sends stress to the spleen gets inflamed, and then the spleen sends inflammatory signals back to the brain, which reinforces the feelings of lethargy, anxiety, and depression. It's a vicious feedback loop.
That completely shatters the idea that mental health and physical health are different things. If my spleen is driving my depression, the boundary doesn't exist. It's a single, integrated network.
It completely erases the line. The body is one system.
Okay, so we've explored the chronic side of things. We see how the spleen adapts, swells, and misbehaves over months or years of stress, whether that's from a parasite, a sick liver, or a stressful life. But the spleen's physical location, combined with its incredibly weird internal plumbing, leaves it uniquely vulnerable to sudden catastrophic emergencies. Which brings us to the final act of the spleen story. Let's look at the acute failures, the vulnerable organ.
The vulnerabilities of the spleen come from both the inside and the outside. Let's start from the inside with the blood vessels. When we look at the splenic artery entering the hilum, the root of the spleen, it exhibits a major evolutionary design flaw.
A design flaw?
How so? As the main splenic artery approaches the organ, it splits into several smaller branches called segmental arteries. Each branch plunges into the tissue and is solely responsible for supplying oxygenated blood to one specific territory or segment of the spleen.
That sounds organized. What's the problem?
The problem is that there are no anastomoses between these branches.
Okay, anastomosis?
Yeah.
Break that down for me.
An anastomosis is a biological bypass. It's a collateral route. In many organs, the blood vessels form an interconnected web. If one vessel gets blocked by a blood clot, the blood can just take a detour down a side street, flow through a connecting vessel, and still reach the tissue to keep it alive.
Like driving in a city on a grid system.
Yeah.
If Main Street is closed for construction, you just take First Avenue around the block. You still get home.
Exactly. But the spleen doesn't have a grid system. The segmental arteries are what we call end arteries. They do not connect to each other. There are no side streets.
So it's like a city built with only one highway leading into each neighborhood and no connecting roads between them.
Precisely. And this is a massive vulnerability. Because if a blood clot, an embolus, travels from the heart and lodges in one of those specific segmental arteries, the blood supply to that exact territory drops to zero instantly. Because there are no detours, the tissue cannot get oxygen.
And what happens to tissue that doesn't get oxygen?
It suffocates and dies. We call this a splenic infarct. A wedge-shaped section of the spleen literally dies and turns to scar tissue.
That sounds incredibly painful.
It is agonizing. It presents as sudden, sharp, severe pain in the left upper quadrant of the abdomen, often radiating to the left shoulder, a phenomenon known as Kier's sign.
Why the shoulder?
It's referred pain caused by the inflamed spleen irritating the diaphragm, which shares a nerve pathway with the shoulder. Splenic infarcts are particularly common in patients with sickle cell disease, where the deformed, crescent-shaped red blood cells logjam and block these end arteries completely.
I just can't fathom why evolution would build such an important blood-heavy organ with no bypass system. It seems like a glaring oversight.
Evolution is often a series of compromises. But ironically, this flawed segmental design provides a massive advantage for modern trauma surgeons.
How does lacking a bypass help a surgeon?
Because the segments are completely isolated from one another in their blood supply, a surgeon can perform a partial or subtotal splenectomy.
Oh, I see.
Yeah, if a tumor or a traumatic injury is localized to just the bottom third of the spleen, the surgeon can dissect out that specific segment, tie off its specific segmental artery, and cut it away. Because the rest of the segments have their own independent, unconnected blood supplies, they remain perfectly healthy and fully functional. The surgeon saves the organ.
Okay, that is a brilliant silver lining to a bad design. So that's the danger from a clot on the inside. But the spleen's most famous vulnerability comes from blunt force trauma on the outside.
Yes. The spleen is the single most frequently injured abdominal organ in blunt trauma. High-speed car accidents, motorcycle crashes, a bad tackle in football, fallen off a ladder.
But wait, earlier you said it was safely tucked behind the ribs. Ribs 9, 10, and 11. Shouldn't it be shielded from impacts?
Their ribs are a double-edged sword. Yes, they deflect minor blows. But if the impact force is severe enough to fracture those lower left ribs, the protective cage becomes a weapon. The jagged, broken edge of a rib can easily puncture inward and lacerate the spleen.
Okay, so the bone cuts it. But what if the ribs don't break? Can the spleen still be injured?
Absolutely. Think about the physical structure of the spleen. It is not tough like muscle. We described it as a dense, blood-filled sponge, and it is surrounded by a very thin, delicate, fibroelastic capsule.
Right.
It is incredibly fragile. If you are in a car crash and your abdomen hits the steering wheel or is compressed violently by the seatbelt, the sheer hydraulic pressure transmitted through the abdomen can cause that thin capsule to burst.
The balloon pops under pressure. And because of the open circulation we talked about, the fact that 10% of your body's total blood volume is flowing through this organ at any given minute, a popped balloon is a catastrophe.
It is an immediate, life-threatening emergency. A ruptured spleen bleeds profusely directly into the open peritoneal cavity of the abdomen. The patient begins hemorrhaging massively on the inside.
What does that look like when a patient rolls through the doors of the ER?
They are in hypovolemic hemorrhagic shock. Their blood volume is crashing. Their blood pressure plummets because there isn't enough fluid to pump. Their heart rate skyrockets to 130, 140 beats per minute, desperately trying to circulate whatever blood is left. They are pale, sweating, and confused because their brain is losing oxygen.
If they're bleeding internally, the doctor can't see it. And if their pressure is crashing, they don't have 45 minutes to sit in an MRI machine. How do trauma doctors confirm it's the spleen that blew up?
They use a bedside ultrasound protocol called the FAST exam, focused assessment with sonography and trauma. It takes less than 2 minutes. The trauma physician takes the ultrasound probe and specifically looks at 4 windows on the torso, looking for black spaces on the screen.
What does black mean?
On an ultrasound, fluid shows up as black. In a trauma patient, free fluid means blood.
Where are they looking?
They look at the pericardial sac around the heart. They look at Morrison's pouch, the space between the liver and the right kidney. They look down in the pelvis behind the bladder. Because fluid follows gravity, blood pools in these dependent spaces.
And the spleen.
Crucially, they look at the left upper quadrant, specifically checking the splenorenal recess, the space between the spleen and the left kidney.
And if they put the probe there and see a massive black shadow?
If they see a large collection of black fluid around the spleen and the patient's blood pressure is crashing, the diagnostic phase is over. That patient is rushed immediately to the operating room for an emergency exploratory laparotomy.
Wow.
The surgeon makes a large incision down the middle of the abdomen, finds the shattered spleen, clamps the splenic artery to stop the bleeding, and removes the organ.
You literally have minutes to act. But what if the crash wasn't as severe? Say the FAST exam shows just a tiny bit of fluid and the patient's blood pressure is stable. Do they still rip the spleen out?
Historically, yes. 50 years ago, any scratch on the spleen meant it came out. But our understanding of the spleen's vital immune function has drastically shifted surgical philosophy. Today, surgeons practice organ preservation whenever safely possible.
Because they know taking it out condemns the patient to a lifetime of immune deficits.
Exactly. So if the patient is stable, they will get a CT scan with intravenous contrast. This allows the radiologist to precisely grade the injury using the AST scale, the American Association for the Surgery of Trauma. It ranges from grade 5 to grade V.
Break those grades down. What's a grade I versus a grade V?
A grade I is minor, maybe a small subcapsular hematoma, a bruise under the capsule, or a tiny laceration less than a centimeter deep. A grade V is a completely shattered, pulverized organ, or a spleen where the main blood vessels have been entirely avulsed, torn off.
So a grade V comes out, no question. Yep. But how do you treat the middle grades? Say, a grade 3 laceration.
If the patient is stable, we manage it non-operatively. We admit them to the intensive care unit. We enforce strict bed rest so they don't dislodge any clots. We do serial abdominal exams and draw their blood every few hours to make sure their red blood cell count isn't quietly dropping. The spleen, incredibly, has a high capacity to heal its own lacerations if left alone.
But what if it keeps trickling blood?
Then we use an amazing endovascular technique called angioembolization. Instead of cutting the abdomen open, an interventional radiologist threads a long, thin catheter into an artery in the patient's groin.
Okay.
They navigate that catheter up through the aorta, into the splenic artery, and right to the specific branch that is bleeding. They deploy tiny metal coils or biological glue to block that specific vessel, stopping the bleeding from the inside while saving the rest of the organ.
It's like doing microscopic plumbing repair through the pipes themselves. But inevitably, some spleens cannot be saved. Whether it's a grade V trauma or severe ITP, or it's destroyed by sickle cell disease, the organ has to go. This brings us to the aftermath. Asplenia. Living a life without a spleen. You survive the car crash, you heal from the surgery, or you just back to normal.
Physically, you might feel normal, but immunologically, you are permanently compromised. You have lost the white pulp. You have lost your primary factory for opsonizing antibodies.
You've lost the ability to paint the Velcro target on the slippery bacteria.
Exactly. And because of that, you are at a lifetime risk of a catastrophic condition known as OPSI, overwhelming post-splenectomy infection.
Overwhelming is a strong word. How bad is it?
It is terrifyingly fast and lethal. Let's compare a normal person to an asplenic patient. A normal person contracts streptococcus pneumonia. They might develop a bad ear infection or maybe lobar pneumonia. It's unpleasant, but their spleen eventually tags the bacteria, the macrophages eat it, and they recover.
Right, a normal immune response.
If a patient without a spleen contracts that exact same bacteria, the bacteria enters the bloodstream. Because there are no opsonizing antibodies to tag the slippery capsule, the bacteria evades the macrophages entirely. It multiplies exponentially in the blood.
Oh, no.
Within 12 to 24 hours, the patient can go from feeling a mild chill to developing fulminant, irreversible septic shock. Their organs fail, and the mortality rate for OPSI can be as high as 50% to 70%, even with modern ICU care.
That is horrifying. A simple infection turns into a death sentence in hours, and the sources mentioned they were also vulnerable to parasites, right?
Yes, particularly Babesia, a tick-borne parasite similar to malaria that infects red blood cells. A normal spleen would detect the stiff, infected cells in the red pulp and call them. Without a spleen, the parasite runs rampant, causing severe, sometimes fatal hemolytic anemia.
So how on earth do you keep a patient without a spleen safe? You can't just put them in a plastic bubble.
It requires rigorous, lifelong medical vigilance. First, proactive immunization is mandatory. The patient must receive the pneumococcal vaccines, the meningococcal vaccine, and the Haemophilus influenza type B, the Hib vaccine.
To replace what the spleen would normally do.
Exactly. These vaccines artificially teach the body to recognize those specific encapsulated bacteria. They also need annual flu shots and COVID boosters because viral infections often damage the lungs and pave the way for secondary bacterial pneumonias to take hold.
Vaccines are a shield, but what happens if the bacteria breaks through? Do they take antibiotics forever?
The protocol varies by age. For young children who lose their spleen, doctors usually prescribe daily prophylactic antibiotics like penicillin or amoxicillin to be taken every single day until adulthood because their immune systems are still immature.
And for adults?
For adults, the daily antibiotic approach is debated due to the risk of creating antibiotic-resistant superbugs. Instead, many doctors use the pill-in-pocket strategy. The patient carries a high-dose supply of broad-spectrum antibiotics like Augmentin or Lidocaine everywhere they go.
Just in case.
Right. They are strictly educated. If they ever develop a fever of 100.4 degrees Fahrenheit or feel a sudden chill, they are not allowed to wait and see if it's just a cold.
They can't sleep it off.
Never. They must immediately swallow the emergency antibiotics and go straight to the nearest emergency room, explicitly telling the triage nurse, "I do not have a spleen and I have a fever." It is treated as an absolute top-tier medical emergency.
It is a high-anxiety way to live. But the human body is incredibly adaptive. If the spleen is gone, does any other organ try to step up? Does the liver try to cover the shift?
The liver certainly tries. The liver has its own massive population of resident macrophages lining its blood vessels known as Kupffer cells. Over time, these Kupffer cells undergo hypertrophy. They multiply and become more aggressive, attempting to take over the microbial clearing function and filter out damaged red blood cells.
But the liver doesn't have that open plumbing system.
Exactly. The liver's circulation is largely closed. The blood flows relatively quickly through the sinusoids. It doesn't have that slow, percolating, open mesh swamp of the cords of Billroth.
Right.
It doesn't have the brutal stave cell obstacle course to physically test the red blood cells. So while the liver provides a backup defense, it is never as exquisitely efficient as the spleen.
It really just highlights the ultimate paradox of this organ. When you look at its design, the spleen is built in part to act as an emergency blood reservoir to save us from bleeding. It literally has smooth muscle fibers in its capsule that can forcefully contract to squeeze extra oxygen-rich red blood cells into our circulation if we are hemorrhaging. It is designed to save us from bleeding out.
And yet its delicate, spongy structure and its fragile capsule make it one of the leading anatomical causes of hemorrhagic death when it is subjected to blunt force trauma. It is built to save us from bleeding, but if struck, it will easily bleed us to death.
A beautiful, complex, but incredibly fragile piece of evolutionary engineering. Well, let's pull all of this together. We have taken a massive journey today. We started in the deep embryonic past, watching a cluster of cells form behind a protostomach, sometimes leaving behind mysterious microscopic clones scattered across the abdomen.
We certainly did.
We navigated the bizarre internal architecture, the white pulp's intelligence hub manufacturing Velcro tags, and the red pulp's grueling open swamp obstacle course where old blood cells meet their end.
We examined how that system breaks down under stress, swelling massively to fight tropical parasites, engorging from the back pressure of a scarred liver, and even inflating in response to chronic psychological anxiety.
And we saw how this vital, silent bouncer, so essential for protecting us from rapidly lethal bacterial sepsis, can be shattered in an instant by a single broken rib. But before we sign off, I promised the listener one final mind-bending thought about the resilience of this organ. We talked about how fragile the spleen is during a trauma.
Yes.
If it ruptures, it shatters. When a trauma surgeon opens the abdomen to remove a shattered, grade V spleen, the cavity is literally filled with pooled blood. And suspended in that blood are millions of microscopic cells from the pulverized organ. Splenosis. Yes, splenosis, the phenomenon of the phoenix organ. Sometimes, even after the surgeon meticulously removes the main organ, ties off the artery, suctions out all the blood, and sews the patient back up, a few of those microscopic spleen cells are inevitably left behind. They spill into the abdominal cavity during the trauma.
And they don't just die.
No, they don't die.
Right.
Without any structural matrix, without any established blood supply, these rogue, free-floating cells can actually take root. They settle onto the surrounding fatty tissue, they embed themselves on the surface of the intestines, they stick to the peritoneum.
It's amazing.
They recruit tiny blood vessels from the surrounding tissue to feed themselves. And over years, they literally grow, replicate, and self-organize into dozens, sometimes hundreds, of brand new, fully functional mini-spleens scattered throughout the entire belly.
It is autotransplantation. The organ that was violently destroyed simply replants its own seeds from the ashes, attempting to restore the immune protection the body lost.
It is the ultimate biological fail-safe, and it happens right inside us. So the next time you feel a mysterious sharp ache in your left shoulder, which, remember, might be your diaphragm's nerve pathway telling you your spleen is unhappy, take a second. Appreciate your unseen immune bouncer. It might be working overtime, filtering out a virus. It might be harboring a hidden clone in your pancreas. Or it might just be quietly executing the most precise microscopic surgery on your red blood cells millions of times a minute, asking for absolutely no credit. Keep exploring, stay curious, and we'll see you on the next deep dive.